Thank you for the organizers of inviting me to tell you something about my experience with mevalonate kinase deficiency, which is of course my favorite disease. I see plenty of patients with it, and I hope to share some of my experiences with you today. Yes, it's working. Let's first start with a case of a patient. So this is one of my patients. I'm an adult physician, just to be sure, so I don't see children. So I get children when they, or no, patients when they reach 18 and come to an adult physician. But there's still plenty of patients with hereditary fever syndromes who are only diagnosed in their adulthood. And this was an example. He was already 33 years old, and he reported that he'd had these episodes of illness since his age 3 months, but no one had been able to make a diagnosis. He gets, by now, only 4 times to 5 times a year. As a child, it was more once a month, episodes of fever of up to 40 degrees, with myalgias, arthralgias, and lymphadenopathy, and he was very tired and lay in bed and lose weight because he didn't have an appetite. And we actually saw him during an episode, and he really had increased CRP to over 215, and he fit exactly the rest of the diagnosis with high IgD as well, and some typical mutations in the MVK gene. So this is one of our typical cases with hyper-IgD syndrome, or mevalonate kinase deficiency, which is a better name actually. So what is the clinical presentation? Usually the children the patients have their first episodes in their first year of life. You can also see that in the graph over here, really about 3/4 of patients really have their first episode in the first year of life. And so if patients are referred with fever since they're 31 years old, then you can practically exclude this diagnosis. The fever attacks last about 5 to 7 days usually, and the typical fever symptoms are of course the spiking fever, but what sets them apart from some of the other fever syndromes are aphthous ulcers that can be quite prevalent, a lymphadenopathy, especially cervical lymphadenopathy, a rash, a typical rash that you can see in the pictures here, and abdominal pain can also be very common. And a common trigger of fever episodes is the vaccination. That's also very often in their first year of life when they get the childhood vaccinations. The ethnic origin, the hereditary is autosomal recessive. As for, let's see, I'm going the wrong way. Bottom. Yes. So today I'm mostly going to talk about the hyper-IgD syndrome side of the spectrum. On the more severe end, you have this mevalonic aciduria, which is even more rare, and we really think it's a spectrum, but the most severely affected kids really have dysmorphic features, have clear psychomotor retardation and ataxia, and often die in early childhood. But in amongst those very severe symptoms, they also have these fever episodes. So there is this combination. And this is just a picture about the prevalence. The estimate is that there are probably about 300 or maybe by now 350, 400 patients worldwide known with it. And you can see in these inventories some bias, of course. On the left, this was the original HIDS registry that was started in the Netherlands. So it's not surprising that half the patients were originally from the Netherlands. Here you have the Eurofever registry, which is European-based and is also very Italian-based, so it's not a surprise that here 1/4 of the patients are Italian. But there is some inheritance factor that in the Netherlands there are some common mutations that really have a hereditary effect. So how do I make the diagnosis in clinical practice? In my opinion, first it has to start off with clinical suspicion, just thinking about the possibility of this diagnosis, and just do keep in mind that it is still very rare. So in general practice, it will be very rare to encounter patients, but it would be a shame to miss them. And what I also find is it's helpful to see a patient while he is ill. If the patient comes to you in the outpatient clinic only at the times when he is not ill, it's hard to get a clear picture of what is going on. What I also find helpful is asking the patient to describe the episodes in detail from the start, because in my opinion, it can be really helpful if the patient really says, oh no, I'm well, and then suddenly it starts like this and this and this, and every time it's the same, then it's more likely to be one of these diseases. While if you were looking at a more autoimmune disorder, the symptoms are usually more vague. Also, what's helpful, if you see the patient when he's ill, you can immediately draw blood and determine whether there's a raised CRP or not, which is a helpful hint. If you want to look at which clinical features to look at, I've just put these up here. These are the classification criteria, so not really diagnosis criteria, but more classification, but they are helpful in clinical practice as well. So I refer you to these papers in arthritis, the Annals of Rheumatic Diseases in 2015 and 2019, and you can read up about it. So to continue, of course, IgD always comes up, and IgA that can be raised. So how about them? What do we think about them? Well, they are sometimes helpful if you do keep in mind that they are raised in only about 70 to 80% of these patients. So they are not obligatory. You can have a genetically proven MKD with a normal IgD. What is also good to know is you don't have to draw the blood at a fever episode. It will be as much raised in remission as in a fever episode, so that makes it easier. And it can vary a lot in life. So these are separate patients that we measured along the years and just measured their IgD with a proven genetic diagnosis. So you can see it can be very variable. Interesting is that the mice model also shows high IgD, so it must have something to do with the disease origin, but we still don't know what. And there's a huge differential diagnosis for raised IgD. If it's very high, you practically only left with malignant lymphomas and things like that. But the slightly raised IgD can occur in a lot of other diseases, including a lot of other autoinflammatory disorders, but also smoking, etc., can raise your IgD. So don't be fooled by that. Next step, the genetics. I do consider the genetics as central to the diagnosis, which is of course hard to do if in those countries where genetics are harder to reach. The mutations are in the mevalonate kinase gene. They're all over the gene, so there's all kinds of areas, although there are some preferent or very frequent mutations, which include the V377I mutations, which can be found in almost half of the patients. The patients are usually compound heterozygous for 2 different mutations, and this second one is also very common. So these are the most common mutations. So what is mevalonate kinase? Very briefly, it's in the isoprenin pathway. Up here, it's an enzyme which converts mevalonate to mevalonate phosphate, and the end products include cholesterol, but also some other end products. And patients with mutations really have decreased enzyme activity of this enzyme. And that brings me to another diagnostic test you can do. If you have it available in your center, mevalonic acid in the urine can be very helpful, but you do have to collect urine during a fever episode, especially in the patients who really have the HIDS phenotype with fever episodes, but in between they're healthy. They can have a normal mevalonic acid in the urine in between. So you do have to catch the urine when they have a fever attack, and you do have to have specialized lab doing it. So the regular or metabolic screen of urine may not be good enough. And this is more a specialized test. I don't usually, the last one, the enzyme activity, I don't use it in my regular clinical practice, only for research purposes. You need really either lymphoblasts or fibroblasts, and need to send it to a special laboratory. So that's just if you have access to it. One brief slide on the pathogenesis. The short answer is we don't know exactly. what the link is between mevalonate kinase and the fever, but we do know more and more lately. The most likely link is with the end product of isoprenylation of proteins. So isoprenylation of proteins means that isoprenylate groups are linked to certain proteins like ROS and ROX, making them more membrane bound. And if these proteins are not isoprenylated, they stay separate from the membrane, and that can have all kinds of signaling effects. So that's the idea, and the consequences include increased IL-1, something to do with mitochondrial stability, and also some evidence for defective autophagy mechanisms. So, but there's a lot of work still to be done in that area. So complications that we see, there's a relatively large group of HIDS patients who luckily don't get complications, but these are things that can occur. Some kinds of fulminant colitis or certainly some perianal fistulas and persistent fistulas can occur in patients. There's some reports of respiratory tract infections, although that is hard to distinguish from at the first place, the HIDS attacks themselves. Of course, you know, someone who presents with fever and adenopathy, it can regularly lead to the suspicion that it might be an infection. So that is hard to distinguish. And also now that a lot of patients are getting IL-1 blockade, it's also hard to distinguish whether the infection is due to the HIDS or due to the treatment that they're getting. In some patients, we see kind of skin, more vasculitis kind of lesions at some point. This man presented one episode with very fulminant skin involvement, and here are some kind of, this looks like a little bit Henoch-Schönlein purpura. A dreaded complication, retinitis pigmentosa, so an eye involvement. In some cases, we've seen macrophage activation syndrome. Luckily, it's rare, but it does occur. And also rare, but it does occur, is AA amyloidosis, and about 4% is the estimate now. So to move on to treatment. Before IL-1 inhibitors existed, we usually used NSAIDs or some corticosteroids. This, you can see, was only very partially effective. Red here is ineffective. Yellow reported a partial effect. So all these treatments were not very effective. So the field changed a lot when IL-1 inhibitors became available. These are from the Eurofever papers. Here you can see a different diseases. Here is HIDS or MKD, and you can see the anakinra was more effective than the previous treatment. Although if you compare it to the other disorders, it was still a bit lacking. So it is one of the among those four. It can be the harder disease to treat or to get really a response. You usually will get some response, but to get them really attack-free is more difficult. And this is studied with the, so the previous slide showed anakinra just on continuous use for prophylaxis. Well, Dutch people are usually very pragmatic and down to earth, and a lot of patients, adult patients who only had 4 attacks a year or 3 attacks a year, they came to me and said, do we really need to inject ourselves every day when we only have attacks 3 or 4 times a year? Can't I just inject when I have an attack? So that's what we studied then in 9 patients. So we first asked them to live through an attack and not take any treatment. So you can see the amount of time they had fevers and some clinical symptoms is really up to 5 days. And then the next time they could come and get the treatment, they did have to report to hospital first and get some measurements. So it was still 1 day or 2 days delay, but you see a strong effect on the fever episode. The fever will really go down within 1 or 2 days, and also the symptoms are gone soon, and the attack really becomes much shorter. And now I use this in clinical practice in some of the patients, and they have the treatment at home. And if they really know their disease well, they can start earlier, because that's things to watch out for. Really start early. If you wait 2 or 3 days to make sure is it really a fever attack, then you're usually too late. The fever attack is in full swing, and maybe the anakinra will shorten it for 1 day or something like that, but you don't get the results like you see here if you wait too long. And also don't stop too early. If you start very soon, the patient will feel better within 1 or 2 days and will have the feeling, oh, I can stop again. But that often leads to disappointment, because then 3 or 4 days later the attack flares up again. So that's also what I recommend. Don't stop too soon. So do inject for 4 or 5 days and then stop to make sure it's really gone. And I also don't recommend it in patients where they have an attack interval, if they have an attack more than once a month. Once a month is really borderline. If it's more frequent than that, you get a kind of yo-yo effect of up and down, and it's not useful. So then at those periods, I do recommend patients treat themselves continuously. Now, of course, lately we've had the new drugs, the Canakinumab. So you have the Spanish study, which was an open-label study in 6 children and 3 adults that showed a very good effect of Canakinumab. And then, of course, the cluster study, the umbrella trial, which I won't go to in all the details. You probably heard about it already in one of the other talks, or will hear about it. But if you see the results here of how many people had a complete response, as in no fever episodes anymore, you can see for the MKD group, there it can be up to 35 to 57% of patients under the treatment didn't have fever attacks anymore, which is a good result. It also shows you that, of course, there are plenty of patients who do get attacks under that treatment, unfortunately. And in the more open label treatment arm, you can see that as well. In the middle is the MKD arm, and this is just several doses. So there's only a very minority that is sufficiently treated on 1 dose every 8 weeks. And a lot more patients need more. And that's also what I noticed in clinical practice. I have the majority of the patients in my care are now on Canakinumab, and a lot of them do need the 300 milligrams once every 4 weeks if they have a severe period of their disease. So what do I do with patients that are failing on IL-1 blockade? I first go back, is that a right diagnosis? If you have a genetic diagnosis, okay, you know that you're right, but if you are clinical diagnosed, I would first reconsider, are there alternate diagnoses? I also go through, are there any factors that keeping the disease active? So if the patient has a very stressful life, has some, small other medical issues that are keeping the disease active, like recurrent boils or recurrent tooth problems. Also, I want to check, is there really increased inflammation? A lot of the complaints are, of course, fatigue and tiredness. So I want to know, is it really because of the inflammation of the disease? Do I really have to increase treatment, or is it more psychological factors, burnout or over compensation? But in the cases where I'm not satisfied with IL-1 blockade, I can consider IL-6 blockade or sometimes TNF and just try if that is better in the patient. And in some cases of severe mevalonic aciduria, of course, bone marrow transplantation should be considered, but that's outside of this presentation today. And looking at the last slide more broadly at the things, what of course are our goals is decrease the frequency of the episodes and improve the quality of life. Things that I look out for is urinary protein to follow up for the amyloidosis risk. Patient education as well to improve compliance with treatment, and psychological support for patients who really often have been ill all their lives. And here are some references that you can look up for things that I use in clinical practice and you can use while treating the patients. So that's the presentation I have for today. If there are any questions.
Patients that I'm using Canakinumab every 2 weeks, and that seems to control their disease.
Okay, so I'll repeat the comment. So she commented she has 2 patients that she gives a Canakinumab once every 2 weeks, and it improves it better. I have not dared to do that yet. My interval is 4 weeks up to now, but 2 weeks seems so 300 milligrams once every 2 weeks.
A 4-year-old who's on 150 milligrams every 2 weeks who was diagnosed here. And,
right.
And then a teenager on 300 every 2.
Wow.
And that keeps them both under control.
Okay, I haven't gone as high with that doses yet, so yeah.
Is Is there any evidence, and I know it's small numbers, but that if you treat on a more regular basis, you would decrease the risk of amyloid?
So the question is there any evidence that if you treat on a regular basis, you decrease the risk of amyloid? So none of the patients in my cohort, so in the Netherlands, have developed amyloidosis yet. So it's hard for me to tell. I do check up on them on how many episodes they have a year and their protein in the urine. And if I'm not satisfied on one of those two, then I have a stern talk with them if they wouldn't need more treatment. Yes, but yeah, I'm not worried for them so far because I haven't seen it. No.